Thank you, VACCELERATE, to give me the opportunity to present our work about intentions of healthcare workers to get vaccination against monkeypox in France and in Belgium. And so I will also talk about intention to participate in vaccine clinical trial in the context of the outbreak of monkeypox in Europe. So my name is Amandine Gagneux-Brunon. I am ID physician in Saint-Étienne at the University Hospital and associate professor in ID. So I will also thank you the HiReVac network, our French network for clinical research in vaccinology. So first, my co-disclosure. So I am PI and sub-investigator in different industrial trials. I received research grants from the industrial companies and different travel supports. But when I am a member of board, I don't have any personal payments, but only payment to my institution. So just have a look back during the monkeypox epidemics in the European region. So a total of 25,000 cases were reported from May to the 22nd of November. And so the most affected countries in Europe were Spain, Germany, and France. And in healthcare workers, there were only 5 healthcare workers cases due to exposure, professional exposure. 4 healthcare workers were wearing adequate personal protective equipment, and contamination occurred through body fluid collected samples, for example, and 1 didn't wear any personal protective equipment. So in France, we reported more than 4,400 cases, and in Belgium, where we collect also data, 789 cases were reported. So before wondering if it's very important to convince healthcare workers to get vaccinated against monkeypox, we have to look to the risk of exposure. And so I found this work published in Lancet Microbe in October, which demonstrated that environmental exposure is very frequent when we are taking care from monkeypox patients. And they collected different samples, notably samples in protective personal equipment like masks and gloves, and found them very positive in PCR. So you can also see that positive samples were found in the room where healthcare workers are taking on and taking off their personal protective equipment. So notably in Brazil, different case report in 2 nurses exposed to the same patients were identified with, they used PPEs, but they were exposed to fomites and developed monkeypox infections in this case. So it's possible to be exposed and to develop monkeypox when we are taking care of monkeypox patients. But the risk is probably low, and in this publication in Colorado, you can see that adherence to personal protective equipment is not around 100%. Gloves and masks are not currently and frequently used when physicians are exposed to monkeypox cases. But in spite of low adherence to this equipment, there didn't observe any cases in healthcare workers exposed to monkeypox patients. But we can see that exposure was the risk classification was low or uncertain in this case. So there are few recommendations for healthcare workers vaccination in the context of monkeypox infections. And so in the US, in May 2022, 2 vaccines are recommended, and they were authorized in prevention of monkeypox since 2019. What type of healthcare workers are targets for monkeypox vaccinations? First, research laboratory personnel, clinical laboratory personnel performing diagnostic testing for orthopox viruses, designated response team members, healthcare professionals who administered ACAM, the replicating smallpox vaccine, and healthcare providers who care for patients infected with orthopox viruses. So the vaccine schedule is a primary vaccination with 2 doses, 28 days apart. And in this recommendation, they recommend the use of a booster dose every 2 years with this replication deficient MVA vaccine. So it could be interesting to focus on monkeypox vaccination acceptance in healthcare workers, notably if booster doses are required in the future. So the World Health Organization published different guidance during the monkeypox outbreaks. And in June 2022, they considered that healthcare workers at high risk of exposure were target population for monkeypox vaccination. In August, it was always the same recommendation. But in November, this recommendation was revised, and they only considered healthcare workers at risk of repeated exposure. So in France and in Belgium, we don't have any specific recommendation for healthcare workers. We have recommendations for laboratory personnel potentially exposed to orthopox viruses. So why it's important also to assess in this context of outbreaks and emergence to acceptance in healthcare workers, and notably in France and in Belgium, it's because we are hesitant countries about vaccinations. And we can see that in France, the Vaccine Confidence Project observed a decrease in vaccine confidence, notably in the healthcare professionals between 2020 and 2022. And so the COVID-19 vaccine was not mandatory in Belgium for healthcare workers, but it was in France, and maybe it could have an impact on vaccine acceptance in France in the future for healthcare professionals. So we performed a cross-sectional online anonymous survey using a snowball sampling with the limitation that which are indicated. And we collected demographic characteristics. We evaluated vaccine readiness with the 7C model published by the team of Cornelia Betsch. We also assessed COVID-19 vaccine eagerness and the perceived health potential threat for different outbreaks and pathogens, and the attitudes towards monkeypox vaccines and attitudes towards clinical trial participation for a monkeypox vaccine. I would like to come back to the vaccination readiness. It's concepts and published by the team of Cornelia Betsch in July. And you can see that we tried to evaluate 7 components of vaccination readiness with confidence, complacency, and constraints, which are in the Surge Working Group model for vaccine hesitancy, but also calculation, collective responsibility, compliance to the over measurement for containing epidemics, and adherence to conspirationist theories. So we collected our information between the week 24 and the week 32. And you can see that it was the greatest period for new cases of monkeypox report in Europe. And you can see that France was in the epicenter of the monkeypox outbreaks in Europe. So our survey was addressed thanks to social networks, notably, and our intranet in our hospitals. And so we collected 948 responses, and only 397 were from healthcare workers, with another representation of physicians and pharmacists. So mid-age of our healthcare workers were 43.7 years old. And of course, we had more response for women, and a great majority were medical doctors or pharmacists. Less than 10% of our healthcare workers reported multiple sexual partners in the previous 3 months, which was a risk factor for monkeypox infection. And more than the half of the population was not previously vaccinated against smallpox. And adherence to seasonal flu vaccination in the last season was around 70%. So we also asked them where they were working, and we collected answers from ID healthcare workers in infectious disease departments, but also in family practice. And any healthcare workers work in different units. It's the reason why the total is over the number of healthcare workers. The first point is that the concerns about infectious disease differed with the different pathogens. You can see that here it's a Likert scale. 1 is I'm not very concerned, not at all. And 5, it's I'm very concerned about the epidemics. So you can see that for the monkeypox emergence, the majority of healthcare workers did not consider that it's a threat for public health, and they have great concerns about Ebola outbreaks and the persisting of HIV epidemics, and about polio reemergence and measles. So most of the healthcare workers did not consider monkeypox outbreak as a threat. So if we consider attitude towards vaccine in general in the surveyed healthcare workers with the 7C readiness vaccination scale, you can see that most of the healthcare workers were confident. And for the complacency for every vaccination, they are not complacent because the scale is reverse coded. And they did not consider vaccination as a constraint. They calculate the personal benefits and risk ratio for them before decision making for vaccination. They consider the vaccination as a collective responsibility. They are not completely compliant to the other containment measure, and they did not adhere to conspiracy theories. So we also asked them if they had a previous attitudes of vaccine hesitancy before COVID-19, because we thought that COVID-19 vaccination was another question and maybe was in part responsible for vaccine hesitancy. So we can see that before COVID-19 pandemic, 26% of the healthcare workers responding to the survey had a previous attitude of vaccine hesitancy. Considering vaccine eagerness, in spite of vaccine hesitancy previously, we can see that a great majority of the healthcare workers were eager to get COVID-19 vaccine, because the majority received it as soon as they're being eligible, and 15% of the healthcare workers were vaccinated before being eligible. So you can see that a very few number of the respondents were unvaccinated, but you have to remember that in France, the COVID-19 vaccination was mandatory for healthcare workers. So considering the intentions to get monkeypox vaccine, we used 5 situations. First, the acceptance rate was not 100% in a case of contact with a monkeypox case, high-risk contact, and only 55% of the healthcare workers will agree to get the vaccine if the vaccine was specifically recommended for healthcare workers, while 80%, near 80% will accept the monkeypox vaccination if the epidemics extended to the general population and to children. So what are the factors associated with intention to get this vaccine if it was recommended? And only focus on this question because I think it's very important to know what are the factors associated with preparedness to healthcare workers to future outbreaks. So you can see that we observed a difference in acceptance in women and men. There's no impact of age, and you can see that there is a difference between job, and particularly physicians and pharmacists are more often acceptors than nurses and assistant nurses. And you can see that professionals who had concerns about monkeypox infections were more prone to get vaccinated. And unfortunately, healthcare workers, but they are not allowed, who declared to have 2 or more sexual partners in the last 3 months were not more prone to get vaccinated. So we also see an impact of COVID-19 eagerness and an impact of the CDC vaccination readiness. We are here in an univariate analysis. And we also ask healthcare workers about confidence in their healthcare workers, government, pharmaceutical companies, public health agencies, media, and colleagues. And you can see that the confidence is highly associated with attitudes toward monkeypox vaccination. So in multivariate analysis, you can see that the difference between men and women disappeared. And we also don't have any impact of the occupations on attitudes towards monkeypox vaccinations, and only COVID-19 vaccine eagerness and concerns about the emergence of monkeypox were associated with positive attitude toward monkeypox vaccination. So now, because it's a webinar from VACCELERATE, I would like to talk about intentions to participate in the monkeypox vaccine clinical trial. These results are unpublished for currently. So we observed that men were first, you can see that only 28% of the respondents were prone to participate in vaccine clinical trial. And you can see that women were less prone to participate. There's no difference for age. There's a little difference for country, with curiously maybe French healthcare workers more prone to participate in monkeypox vaccine clinical trials than people from Belgium. And so you can see that physicians and pharmacists were also more prone to accept to participate in a vaccine clinical trial. Of course, attitude towards vaccines, and notably COVID-19 vaccine eagerness, was associated with attitude toward vaccine clinical trial participation. And also, we computed a confidence score about the confidence about public health agencies, government, and you can see that it's associated with intentions to participate. Here also the association between the 7C vaccination readiness scale and participation in a monkeypox vaccine clinical trial in univariate analysis. All the factors except calculation were associated with participation in the vaccine clinical trials. But in multivariable analysis, only confidence score and concerns about monkeypox epidemics were associated with intentions to participate in the monkeypox vaccine clinical trial, with respective hazardous ratio of 1.15 and 2.23. So now, to discuss our results, I will just give you some over results about monkeypox vaccination acceptance in different contexts or other countries. And so I identified first publication in Italian physicians with an acceptance rate of 64.4, but it's only on physicians. They didn't collect any information from nurses or assistant nurses. Maybe this can explain the difference between our vaccine acceptance rate and theirs. You can see also, but it was in another context. It was in 2020 to prevent monkeypox outbreaks in Indonesia. And the acceptance rate in physicians was 93.6%. In the same period than for our survey, study was carried out in Chinese healthcare workers, and the acceptance rate was very higher than our observation, with an acceptance rate of 90%. But around 90% of the healthcare workers considered that monkeypox vaccination was necessary to control the current epidemics, and they didn't observe any significant difference between nurses and physicians. So if we focus on factors associated with vaccine acceptance, we can see that attitudes towards COVID-19 vaccines were predictive of positive attitudes toward monkeypox vaccine, maybe because it's really associated with a global attitude, positive attitude for vaccines, but probably also due to a form of eagerness to get the vaccine when we are in a context of outbreak, and then when we have concerns about the outbreaks. So after adjustment, we did not observe any difference between the different professional categories, probably because nurses and assistant nurses had less confidence, are more complacent, less compliant, and did not consider vaccination as a collective responsibility, and maybe because they had lower knowledge. And so I think it's very interesting to understand why nurses and assistant nurses are less confident and more complacent. So we can see that vaccination readiness and the different measurements of vaccination readiness are low impact in multivariable analyses. And we can see that the concerns about monkeypox epidemics is associated with attitude toward the vaccination. And so we can see that it was the same for COVID-19 vaccination. In April 2020, we carried out another study in healthcare workers, and we observed that the acceptance rate was 74%. And at this moment, 48% of the healthcare workers had fear about COVID-19. And for monkeypox in our work, this proportion was only 70%. So the prevalence of previous vaccine hesitancy between this study for monkeypox vaccination and for COVID-19 vaccination at the beginning of the first wave was quite similar, around 25–26%. So probably complacency may contribute to the lack of preparedness for outbreaks, and particularly for vaccine acceptance in healthcare workers. And so just come back to the results of our colleagues from Italy. And we can see that globally, professionals, general practitioners, public health professionals had good knowledge about monkeypox, but the risk perception was very low, and perceived health threat was very was homogeneous, but very easily. It depends on the professionals. And they also compared concerns about different pathogens, and you can see that monkeypox was not really considered as a threat for the healthcare workers, whereas HIV, TB, and COVID-19 still were a perceived threat for healthcare workers. So now, if you come back to the factors, the participation in the monkeypox vaccine clinical trials, we observed that this proportion of healthcare workers prone to participate in the vaccine clinical trial was lower than that we observed during COVID-19, because in our work for COVID-19 vaccination, the potential acceptance for vaccine clinical trial participation was in healthcare workers over 50%. Probably because the vaccine was available when the outbreak started for monkeypox, and maybe because the healthcare workers were also more complacent with monkeypox outbreaks than with COVID-19. And so also now the difference between the first wave of COVID-19 in the monkeypox outbreaks is also the availability of personal protective equipment, which are effective to prevent monkeypox infection. So we also observed that confidence in the system, in public health agencies, government, and healthcare workers are associated with decision-making about vaccine clinical trial participation, even in healthcare workers. So our study suffered from limitations. First, the lack of representativeness due to our snowball sampling. And so it's the reason why we have a great proportion of physicians. And so probably this great proportion of physicians leads to an overestimation of the positive attitude toward monkeypox vaccines. And probably the acceptance rates in the entire population of healthcare workers is lower. But we try to reduce this effect with the adjustment, and notably adjustment on attitudes toward vaccine in general and vaccination readiness. So we have a small sample size, and maybe it's due to the lack of concerns about monkeypox outbreak, because in a shorter time period, in March, April 2020, we collected tenfold more answers for COVID-19 vaccine intentions. So we can see that there is no problem about knowledge about monkeypox infections, because we start our study very early during the monkeypox outbreaks, and 91% of the respondents had heard about monkeypox infections before answering the survey. So in conclusions, attitude toward vaccine in a context of epidemics in healthcare workers is highly variable and should be explored in the different contexts and for the different pathogens, because it can really differ. And we have to work on for our preparedness to next outbreaks and next epidemics, to vaccine acceptance for emerging or re-emerging disease in healthcare workers. Healthcare workers probably underestimated the risk for infections like monkeypox, but curiously, we are not confronted to a lot of monkeypox infections due to healthcare occupation. So adherence to personal protective equipment is sometimes insufficient, and I think it's an important point to encourage vaccination and prevention by vaccine. And so we have to restore vaccine confidence in healthcare workers to contribute and to improve our attitude towards the vaccines against emerging and re-emerging disease. So I would like to acknowledge Nicolas Dauby from Brussels, Elisabeth Botello-Nevers, the Professor Odile Launay, the IREVAC network, and all the respondents to our survey. And I would like to thank you for your attention.
Thanks a lot, Amandine, for this very nice presentation. I don't see any question in the chat. You may raise your hand if you want to ask one. So is anything, so Fiona asked, is anything done to reduce the vaccine hesitancy in healthcare workers in France?
Yes, yes, we try to work on this problem in France, because I think vaccine hesitancy in healthcare workers is greater in France than in other European countries, and so different initiatives are carried out now, and I think we have also to better evaluate the effectiveness of our interventions. We performed lots of educational interventions in France during COVID-19 pandemics, and maybe we missed to correctly evaluate their impact on global vaccine hesitancy. However, the results of the vaccine confidence group project are probably quite pessimistic, and I'm not sure. They only interviewed, I think, 100 healthcare workers or 150 healthcare workers in France, and maybe the representativeness of the healthcare workers in the vaccine confidence projects are not complete. So we will try to do better, and we are working about it. But I think the results are quite pessimistic.
Thank you. I have one question regarding your conclusion, and you claim that the healthcare worker clearly underestimates the risk of monkeypox. However, it seems that the risk of mpox, because we need to call it right now mpox, is quite low. I'm wondering if you indicate in your survey that this vaccine may also protect against smallpox, and that smallpox could be an issue during due to the general conflict in Europe, and namely in Ukraine, and the risk of bioterrorism, for instance.
The question was, the vaccine against smallpox is currently protecting from monkeypox infections. And so we can provide it to get protected against monkeypox. So it was clear that it was the smallpox vaccine we proposed to. And but I think it's our results show how it's important and crucial to understand and to assess knowledge about the risk of emerging disease and re-emerging disease in healthcare workers, and particularly frontline workers, and particularly nurses and assistant nurses. I think the risk is fully understood by ID physicians, but I'm sure routinely I'm really confronted in my own department about lack of knowledge or lack of concerns or threat about emerging disease.
Okay, but if I understand well, you indicate that to have been vaccinated during childhood against smallpox may protect against mpox, but not the opposite. You don't indicate that if you are vaccinated against mpox, you may also be protected against smallpox. Could be
no. Yes, we write that the vaccine was a smallpox vaccine, and I didn't show the results, but people who received smallpox vaccine during childhood were not less prone than the others to get the vaccination. But clearly, we don't write that there will be also protected against smallpox, but we said that it was a vaccine against smallpox, which was used to protect against monkeypox, mpox. So I think healthcare workers should understand that receiving this vaccine, there will be also protected against smallpox, but we didn't ask for their willingness to get protected against smallpox.
Okay. No questions. So I have another one regarding the second part of your talk, which is also quite interesting. I'm wondering. It seems that at least in France, people that were quite hesitant to be vaccinated against COVID-19 claim that for them it will be possible to be vaccinated if the vaccine was French, so produced in France, and the other one with the more the classical platforms and not a new one. So have you been able to interrogate on this particular point? Would you what is your willingness to be included in such a clinical trial if the vaccine is produced in France, if the vaccine is produced with the classical platform or new one, for instance?
No, in this work we didn't. I worked with the data from the COVIREVAC network, and we presented some results at the ECMID. And of course, for people who registers to the platform later, one of the motivations was to get another platform and to be vaccinated in a clinical trial to receive a non-mRNA vaccines. But as we didn't really need, and we didn't know if a new platform will be developed for mpox infections, we did not and we didn't ask this point about mpox. And so we also know with the COVIREVAC results that vaccine clinical trial acceptance is highly associated with attitudes toward vaccines, and probably the people who registered on COVIREVAC because they would like to receive another platform, they registered later after the COVID-19 pass implementation in France, and they represent a large minority of the people willing to participate in a vaccine clinical trial. But it's a specific population, and I think it's raised the question about the possibility to continue to perform clinical trials with placebo for hesitant patients, for example, but it's a provocative question.
question. I have a more, I will say, fundamental question regarding the first part of your talk, because it's not clear for me what is the interest right now, the relevance to vaccinate healthcare workers against mpox. Because if you are not at risk of mpox, there is no herd immunity with this vaccine, so it's not quite clear. It's just to protect again a possible new infection in the future. So how did you manage to try to convince a healthcare worker? What is your the rationale to think that they will accept to be vaccinated?
Yes, I think it's. I share your mind. I think it's not very useful today to vaccine all healthcare workers about against mpox. But I think that self-protection is one of the best reasons to get vaccinated for healthcare workers. We can see it for seasonal influenza, for example. And so I think the question is of interest because it's important to know that to see what factors affect self-protection behavior in healthcare workers when they are confronted to epidemics. And we start our study early during the epidemics, and we don't have any information about the risk to a professional exposure and the risk for infections. And so now the data are very reassuring, but it was not the case at the beginning. And they were reports of professionals infected during healthcare management, particularly in London. In I think it was in 2018. And a professional, after the patients left the hospital, was contaminated, maybe with beddings. And so I think the personal interest to get vaccinated is an interesting point. And maybe we have to focus probably in response to response team to epidemics. And I know that in ID department, for example, vaccine acceptance for emerging pathogens or vaccine acceptance is not greater than in the other department, for example.
But once again, as you mentioned, we have some results with the previous outbreaks, and it seems that the risk for the healthcare worker are quite low. And even at the beginning of this outbreak, we knew that this outbreak take place mainly in MSM and not, for instance, in women's, meaning that healthcare worker will not be at risk of infection. So I was quite surprised to see the high level of vaccine acceptance with this vaccine. And also, as you mentioned, as we need right now, because we don't know exactly the persistence of the protection, we need to perform boost every 2 years, which is quite a busy schedule. So I was quite surprised by the high level of acceptance regarding this vaccine.
Yes, and I think it's a great difference with COVID-19, and probably because the presentation, the clinical presentation, and particularly the over risk for MSM was probably a barrier for healthcare workers to get the vaccination because they don't feel at risk at all. And I think it's one of the risks of stigma to a specific population is because the rest of the population does not be concerned. And I think our vaccine acceptance rate is very overestimated because we have lots of physicians in our sample and pharmacists, which are good acceptors of vaccines in general, and are not the most exposed healthcare workers to patients particularly.
Okay, thank you.
You're welcome.
No question? So if we don't have any more questions, we would like to thank you once again and for this very nice and important result, because to vaccinate healthcare workers, it's a key issue in many countries in Europe. Maybe not against monkeypox, but as you mentioned, against COVID-19 and flu. And it's quite important to have this kind of work on vaccine coverage and acceptance. So thanks a lot, Amandine.
Thank you. You're welcome.
Yeah, thank you very much, Amandine. That was very interesting.
Thank you.
And as discussed, we will publish the recordings on the website if anyone else would like to watch it afterwards.